Hey everyone, welcome to my Day in the Life series here on White Coats and Corgis. Most of you probably know me from Instagram or TikTok, where I make helpful free content for premeds and talk about my journey as a first-generation medical student. My mission here on YouTube is to give pre-med students all the information they need for a career in medicine. So in order to do that, I've teamed up with MedSchoolCoach to create this series where I'm going to do a deep dive on each medical specialty. And I want to start off by saying that it can be really difficult to accumulate the number of shadowing hours you really need to be accepted into medical school. And especially nowadays, this can be really challenging. A lot of physicians aren't open to shadowing opportunities in person the way that they were before. So that is why MedSchoolCoach decided to collaborate with over 20 doctors to give you a behind-the-scenes look at practically every specialty that you might be interested in. And this is all completely free. You can go to shadowing.medschoolcoach.com, register for the program, and then you get to choose whichever specialties you're interested in to shadow. At the end, you can fill out a short quiz, and then they'll give you a certificate of completion. That way you can count these hours on your medical school application.
And again, this basically explains my thinking in terms of changing careers. And I thought that family practice was the treatment of mostly chronic illness. Most of what you saw was diabetes, hypertension, obesity in the later years, lack of activity leading to complications with knees and joints. And obstetrics and gynecology, on the other hand, made sense. Obstetrics is happy 99% of the time. The 1% that is bad is really bad. Let's just say loss of a mother at the age of 30. But 99% of obstetrics is really happy. Patients are happy. You're happy. Everyone's happy to see a new baby. Gynecology, most of the time, routine pap smears, women who need contraceptive care, adolescent gynecology. It's really a happy, happy experience. And so that's what led me to leave family practice and do obstetrics and gynecology. Obstetrics is the care, so obstetrics and gynecology would be the care of females throughout the life cycle, from adolescence to death. Obstetrics is the care of the pregnant female, and gynecology is care of the non-pregnant female.
Okay.
What I would say from the previous slide, that the life of an obstetrician, what was really nice about obstetrics and gynecology is the combination of surgery and office practice. So I spent one day a week in the operating room. I chose Wednesday for my operating day, so everyone knew, okay, that's my day in the OR. I would spend about 3.5 days in the office seeing patients, and 1/2 day each week was devoted to administrative duties, like filling out patient forms and office billing. So again, obstetrics and gynecology I thought was the perfect combination of medicine and surgery. So we took care of patients. We would assist with their chronic medical conditions, but anything that's complicated, they would see their primary doctor. So the combination of medicine and surgery was absolutely perfect. Obstetrics, surgical, that's just C-sections in case they would need surgery, an operative delivery. Gynecology was basically taking care of abnormal pap smears, doing conizations of the cervix. Of course, when people think about gynecology, they think about hysterectomy. So we treated routine conditions, fibroids, abnormal uterine bleeding. I used a laser for cervical dysplasia. So basically, most people think of gynecology. Let's just say somebody with a big ovarian cyst, and you would take them to the operating room and take the ovary out or remove part of the ovary. So gynecology is partly a surgical subspecialty. And as I spoke about earlier, in my younger days, we also did the cancer surgery. Normally, if it was an ovarian cancer patient and there were issues with node dissection, lymph node dissection, I may do that with the general surgeon. I would do the hysterectomy, remove the cancer, and the general surgeon may do the lymph node dissection. As time progressed and gynecologic oncology became its own specialty, those patients were referred straight to GYN oncology for management. Often Entire weekends were spent in the hospital delivering babies. And we talked about the nuts and bolts of what physicians don't appreciate when they start their specialty. Often it's hard to fathom that you would spend this much time actually between the hospital, the operating room, and your office. And so as a woman, that was, like I said, I think the toughest issues for me were gender issues. I was married, I am still married to another physician who is retired also. And it turns out that my last check, about 43% of women physicians are married to other physicians. The reason for that, you spend so much time in medical school. Now, I decided to present two cases. I didn't put an obstetric case because obstetrics is, everybody knows what it means to be pregnant and have a baby and to go to your doctor and have your doctor help you bring this baby into the world. That's basically, how do you say it? Everybody knows that. And so I chose an abnormal pregnancy as the first case. This is a 35-year-old woman who presented complaining of blood in her urine for a week. She denied abdominal pain or back pain, stating that her last menstrual period was 6 weeks ago. The initial pregnancy test was negative. Our urinalysis revealed many red blood cells, few white cells, and few bacteria. Urine culture is negative. The initial pelvic sonogram reveals normal ovaries and a normal sized uterus with a small 2-millimeter sac-like structure requiring correlation with the pregnancy test result. And again, the pregnancy test was negative on presentation. And this patient presented due to blood in her urine. 1 week later, this patient reports erratic vaginal bleeding without abdominal or pelvic pain. The serum pregnancy test is now positive with a beta subunit of 898. Repeat serum pregnancy test level 48 hours later is 933 with an unremarkable pelvic sonogram. This patient is given ectopic precautions and instructed to return in 72 hours. Now, I should say that in a normal pregnancy, the beta subunit level will double roughly every 24 to 48 hours. So we know that this is a failed pregnancy. Due to a snowstorm, the follow-up appointment was canceled by the office, and she was given another appointment 1 week later, which she missed. The patient finally presented 2 weeks following the initial missed appointment for a pelvic ultrasound and was found to have a 5-millimeter sac in the uterine cornu without evidence for a rupture. At this point, she is referred immediately to the emergency department for treatment of her ectopic gestation. Next slide. Discussion. This patient missed an opportunity for treatment of her ectopic pregnancy with a single dose of methotrexate. We use methotrexate for early failed pregnancy because it is one dose and it is about 95 to 99% effective in killing any aberrant pregnancy tissue. However, by the time this patient presents to the ED, she is experiencing mild back pain and continues to suffer vaginal bleeding. She was taken to the operating room for surgical management of her ectopic gestation. A laparoscopic salpingectomy with removal of the products of conception was accomplished, and she was discharged in stable condition the following day. Now, so an ectopic pregnancy, think about ectopic. An ectopic pregnancy is a pregnancy which is growing in some place other than the uterine cavity. The next picture is this is the cavity of the uterus, which is where a pregnancy should grow. Now, the next slide, where it says ectopic pregnancy, if you point to that little structure where it says fertilized egg implanted in the fallopian tube, yes, that pregnancy is implanted in the actual tube. So ectopic pregnancy refers to any pregnancy that implants itself anywhere other than the cavity of the uterus. The picture on the left, can you point to see the red arrow? Yes. So if you look, the blue arrows delineate the uterus itself. Okay. This, in the red arrow, if you can see, there's a ballooning structure. If you look at the opposite tube, the white structure on the other side, can you point to that white ovary? That's the ovary and the tube on top. So this person's already starting to leak blood, although the ectopic pregnancy does not appear to be ruptured. And this person would require operative management of this ectopic gestation. Okay, the next case. This is a 68-year-old postmenopausal female who is relatively healthy and presents due to intermittent vaginal bleeding for 2 weeks. She denies abdominal pain, pelvic pain, nausea, vomiting, or loss of appetite. Her past history includes mild hypertension and treatment of breast cancer 10 years prior. The pelvic sonogram reveals an abnormally thickened endometrium of about 6 millimeters with suggestion of a polyp. A polyp is a finger-like structure that often will grow in the lining of the uterus, and they're most often benign. The remainder of her pelvic sonogram is unremarkable. An attempted office endometrial biopsy failed due to cervical stenosis, which is common in a postmenopausal patient. Cervical stenosis just means that the cervix is the mouth to the womb. In postmenopausal patients, due to lack of estrogen, the cervix often becomes tight. They're no longer having menstrual cycles, and it's very difficult to cannulate the cervix to enter the uterus. This patient was then taken to the outpatient operating room for DNC and polypectomy 2 weeks later. The final pathology report revealed a uterine polyp with a focus of adenocarcinoma. This patient was then referred to a gynecologic oncologist for definitive treatment. So again, this points out my former point that when patients have gynecologic cancers now, they often are sent directly to a gynecologic oncologist. 2 weeks later, this patient was seen at a cancer center, a tertiary cancer center, and was treated with a robotic assisted total hysterectomy, removal of the ovaries, tubes, and a few of the lymph nodes. And we can go to the next slide. So again, I know that the left slide, there is a structure within the square. That is what a polyp may appear to be. It could be a polyp or a fibroid. You wouldn't know until you take it out. This particular structure seems to be on its way out already, but this would be a cause of abnormal bleeding. And on the opposite picture, if you look, there's a yellow structure. Yes, that's clearly abnormal. The remainder of the womb is smooth and silky, and this would also represent abnormal endometrial tissue. Now, if this were a young person, I wouldn't assume it's cancer, but if it were a 68-year-old, this is likely to be a malignant process. So this is just basically giving you an idea of what abnormal structures in the uterus might look like. And this particular 68-year-old patient ended up with the final pathology report of an adenocarcinoma of the endometrium. The final follow-up postoperatively, because the cancer occupied greater than a certain depth of the endometrium, this patient was referred for intravaginal radiation postoperatively after her vaginal cuff was healed. And she did well. These patients with gynecologic cancers, if you are in an area with a tertiary care center, those patients are referred, as this patient was, referred to a tertiary care center to be treated by a gynecologic oncologist. The DNC is done by the office gynecology. So, but once the diagnosis of cancer is made, we would send those patients to GYN oncology. But again, in 1977, we were the gynecologic oncologists. Mm-hmm. There was no developed specialty of gynecologic oncology. So you ask, how has this specialty evolved? Again, the development of subspecialists has markedly been expanded. One subspecialty we did not talk about, we also have infertility specialties. Excuse me. Those are called reproductive endocrinologists. So they are OBGYNs who go into infertility medicine. So if someone comes in and they've been trying to get pregnant for a year and we've done a basic workup, we can't find anything. We've basically given them instructions about the best time to get pregnant. And we've done a workup. We haven't found any reason as the source of their inability to conceive. We would also send those patients right over to reproductive endocrinologists. Gynecologic oncology would be an additional 2 years of subspecialty fellowship. Reproductive endocrinology, again, an additional 2 years after the 4 years of fellowship training. And so maternal fetal medicine, the same. After you finish an OBGYN residency, you would do an additional 2 years of a maternal fetal medicine fellowship. The other thing I also wanted to mention, that maternal fetal medicine is so developed now that I'm not sure if you guys are aware, there are certain surgeries that can be done on a fetus in utero. Yes, there have been successful surgeries on fetus, the kidney of a fetus I've read about. So that field has blossomed also. So what I would say, what I've seen in the last 30 years, the technology, the instrumentation, robotics has made, it's been a dream. So now the same patient I presented the case to, this patient had a robotically assisted hysterectomy with removal of tubes, ovaries, uterus, lymph nodes, and she actually was able to go home the next day. Again, the practice of obstetrics and gynecology proved to be exciting, varied, and always filled with new challenges. Of course, delivering babies hasn't changed, but new diagnostic and therapeutic options for prenatal diagnosis has exploded. There are now tests for earlier prenatal diagnosis of maladies such as Down syndrome, the ability to sample cord blood early, and with the advent of 3D sonogram imaging, a myriad of prenatal problems can be seen and diagnosed early. In addition, the field of intrauterine surgery is exploding. And again, there are some surgical operations that can actually be performed on a fetus in utero without disturbing the pregnancy. Lastly, as for gynecology, again, the advent of robotics has made minimally invasive surgery an option for all but the most challenging of cases. Robotically assisted surgeries mean a few tiny incisions, resulting in less pain and earlier ambulation, with often discharged the same day.